So thank you very much for this kind introduction and for the invitation to speak at this important meeting. It's a pleasure to be here. For those that are worried, having listened to all the cells and the parasites over the last hour, I promise you I will not mention a single molecule, cell, or pathogen in the next hour. So what I propose to do is, over the next 30 minutes, give a little bit of context about migration and health, and I hope by the end I would have convinced you that if it is not the defining issue, it is definitely one of the defining issues of our time. I'll describe the important work we did, which we published in the Lancet Commission, and then I'll use 3 case studies to articulate the story that there is some good news, there are areas where we're doing really well, and there are places where we need to do better, and then conclude and let you judge whether it is the defining issue of our time. So in our Lancet Commission, we concluded that there are about 1 billion people on the move. The majority of these are actually internally displaced people within countries. Only about 1/4 of people who are on the move are crossing international boundaries. And this cartoon here shows the direction of where people are moving in the different parts of the world. And you can see that about 37% of all of that international migration, a lot of it labor migration and students and some refugees, is actually in the global south, so between countries in the global south, rather than between the global south and the north. The risk of illness or disease in migrants is hugely dependent on the number of diseases that exist in those countries of origin, the nature of their journey and exposures during those journeys, and ultimately how they are treated when they arrive at their destinations, around access to care and lots of other host factors. A lot of the movement, as you can see, is in the global north, of the order of 50 million, but a large proportion, about 90 million, is south-south movement, and then there is a proportion that is between the global north and global south, as shown in the second cartoon. Migration is intensely political, and you would see from the news you listen to, from the newspapers you read, that the link between migration and politics is very significant, whether in the sense of the right-wing press trying to assert that migrants bring in diseases and infections, as from this cartoon in Fox News, or it is in the form of the tragedy that is Brexit, where we were lied to about resources to the NHS, and ultimately those resources are not available. If anything, our NHS continues to get worse. For the international audience, NHS is in our National Health Service, and the Brexit Response campaign that was misleading. And it is not going anywhere. Our tabloids continue to cover this story, with this headline recently, with our Home Office Minister challenging our current king about the deportation of people to Rwanda, and indeed all over the world. Tomorrow, we probably would end up with a right-wing leader for the first time since before the war in Italy. So migration is an intensely political issue. The other contextual issue is, it's not that countries cannot see the moral obligation to do something right about migration and health. There are numerous policy documents going back to the end of the war, multiple documents that have been put together, consensus between countries to say, these are the right things to do. This is what the obligations of each nation state is to migrants in terms of their health and their ability to move. Unfortunately, it's not due to the absence or lack of these policy documents, which culminated in about 4 years ago in 2 key documents, the Global Compact on Safe Orderly Migration for Migrants and the Global Compact for Refugees. It isn't that we don't have those documents, it's simply that they are not being implemented by countries. So in reaction to this context, the political importance, the tragedy in lack of access to care for migrants, and the impact on that on the health of multiple populations, I, in discussion with the editor of the Lancet, set up the UCL Lancet Commission on Migration and Health about 6 years ago. And we sat down and brought experts from multiple disciplines, ranging from sociology to politics to public health to clinical medicine, law and humanitarianism and anthropology. And we put together people from different parts of the world and spent 2 years distilling the evidence base. What are the things that you need to do to make the health of migrants and their host populations better? And I'm pleased that we published a report that is seminal in a sense of having impact on policy in multiple countries and multiple regions. Some of our key conclusions in the Lancet Migration Commission is that the wider determinants, as you would have heard in previous talks today, are absolutely important to health. the conditions that migrants have in the countries they originate from through their journeys and ultimately in their host country in terms of education, their socioeconomic status, and all the wider determinants of health are key to the health of migrants when they arrive in the respective setting. So in any attempt to solve the problem of migrants, you cannot ignore the wider determinants of health and inherently the inequalities that comes therein. We also concluded that one of the key issues that affects migrants directly is access to healthcare. And unless you can address access to health and to public health, you are unable to solve some of the major challenges that affect migrants. And we think that you can look at it from a supply-side angle as well as from a demand-side angle. So make sure that the right services that are culturally appropriate are provided, but that in doing so, that migrants recognize that they are able to access those services. And then you take into account the issue at the global, regional, and national level to lead to ultimately equity of access. The other key thing we did is we tried to make sure that we look at the evidence base about all of those misleading myths that I mentioned earlier. For example, the narrative in the media that migrants are bringing in infections and they're infecting host populations. Or, for example, migrants have tons and tons of babies. Or, for example, migrants would somehow overuse healthcare. And we're able to show systematically that if you look at the evidence and you're objective, there is actually no fact behind that. In multiple countries and in multiple settings, once migrants settle in a new place, they adopt the behaviors and cultures of places at a pace that is actually a lot more rapid than you think, and that therefore many of those statistics are just completely inaccurate, and that the right-wing press is purposely misleading people to serve their unvested interests rather than because actually any of them are true. And I think that information we provided has been used effectively by many others for advocacy. So I'm now going to move on and talk about 3 case studies. The first around Ukraine. I think I picked on this one not only because it is present and just next door to us and happening, the tragedy that is unfolding in Ukraine and the displacement of large numbers of people, but importantly because of the fantastic and amazing response of the European Union to the tragedy in terms of the treatment of the people that have been displaced. The sort of reaction that we must have to migrants and refugees is finally happening. I'm going to tell this story through the lens of my colleague, Professor Paul Spiegel, who is based at Johns Hopkins, and he was seconded for about 6 weeks earlier this year to Poland, and then was able to travel supporting the WHO and national governments in their response in Slovakia, Romania, and the Czech Republic. So all of the pictures and data I'll show relates to the work that he's doing. But before I present some of that, just a reminder about the scale of this tragedy. Over 7 million people recorded across Europe displaced. Of those, over 4 million people have been registered as needing temporary protection under national or UNHCR-related schemes. Absolutely outstanding that at this age in Europe we have this scale of disruption to people who do not have the ability to look after their basic needs. This is what I'm really, really proud of. The immediate reaction by the European Union and the decision that we will do the right thing. We will offer accommodation, schools, healthcare, jobs to these displaced people. And the generosity of ordinary citizens from across Europe to respond to these individuals is something to behold, and that should be the way we rightly act when we are faced with a challenge such as this. The response, as seen from the lens of Paul Spiegel going around the country, can be captured in 4 key stages. The journey that the migrants undertake, often having just come out of conflict with people shooting and bombing their homes, and that travel between the different parts of Ukraine all the way to the border of the European Union. The ability to then secure temporary residence, often in very difficult circumstances, and then ultimately emergency referrals to surrounding countries, and for some, a small number, return back to Ukraine. The main issues around the refugee journey relates to the ability to access first aid, because there are people with actual injuries and therefore they need access to first aid. Continuity of care for people with chronic diseases, diabetes, hypertension, and where they would access their medicines in a new country that they have no familiarity with. The provision of emergency care if anything goes wrong along that journey. The ability to maintain surveillance so that we know the burden of disease in these refugees and migrants, and the provision of up-to-date information as you're on the move as to where you'd find services and where you can seek help. We then move on to the challenge of how do you provide temporary residence and healthcare in the context of temporary residence. And there is a whole variety of issues. Again, the response by Europe and multiple European countries has been exemplary. Issues such as hospital capacity and thinking through and making sure that we don't exceed capacity. And fortunately, to date, most countries have managed this without exceeding local capacity. Ensuring that people can access general practitioners to be able to get into the health system and not overload the health system. Ensuring more broadly access to a whole variety of other health interventions, including for vulnerable groups that are displaced. Availability of services that are responsive to language and culture of Ukrainians and displaced people, but also taking into account the fact that there are some diseases that are prevalent in Ukraine, for example, TB and HIV, that are no longer common in many of the countries people are settling in. And do we have the right protocols and guidelines to respond to these individuals and offer them the best care? Mental health, vaccination, outbreaks. Of course, when you put people in temporary settings and on the move, there will be outbreaks, and making sure that you respond to that. And for people fleeing violence, really important, gender-based violence and victims of gender-based violence from the Russian forces that are invading people's homes and houses. Important in such a response that we have numbers, we have accurate surveillance data, and some of the activities laid by the European Union, the WHO and others and national governments is the idea that we must have good data on the demographics and correct denominators to calculate how many people there are, ability to communicate some of that information when there are outbreaks or incidents of disease through established systems such as the early warning alert response system, the EWARS, as well as electronic sources, including social media and collection of surveillance data through new and innovative approaches, but also surveillance systems, the traditional surveillance systems of hospital data and general practice data that are then collated to make sense. So for me, all of this activity is underpinned and was only successful because of commitment by governments and because of appropriate governance by states to take charge of the situation and deliver. Ultimately, as we move into the future in this protracted conflict, we must think about how do we ensure the sustainability of this if the conflicts continue for much longer? How do we ensure that there isn't fatigue in the hosting of refugees? What are the longer-term alternatives for these populations as they settle in numerous European countries? What about the consequence of the current inflation and economic downturn in many European countries? Is that going to lead to less access to these individuals in their settled countries? We must have policies and interventions, if that happens, that supports the most vulnerable among the migrants, i.e. individuals who cannot access healthcare easily because they are poorer and cannot pay insurance premiums. And ultimately, we must adapt our health systems and healthcare financing to make sure that we are able to cater for the Ukrainian population that are now living amongst us. Having said that, I have some flip side of this issue. I do think that there is a global moral failure. I think, as rightly articulated by Dr. Tedros, if you compare this amazing response that I think is absolutely right that we had to Ukrainians with what's happening in Ethiopia, whether you agree with the politics and complexity of what's happening, there are human beings suffering there, and the response is anywhere near the same. We currently have the floods in Pakistan, and people are being displaced in large numbers, and we fail to, as a global community, respond in the same way, with the same generosity when it comes to health and humanitarianism. I think we have a moral responsibility to tackle this global moral failure and do what is right, irrespective of where tragedy happens in the world. I'll move now to my second case study, which is on the climate crisis, migration, and health. I know there was a talk earlier today on the climate crisis, and I hope you'd agree with me that when we talk about the anthropogenic climate change and the effect it will have on our planet and the ecosystems that we live in, the ultimate consequence when this planet ends is our complete demise. And I don't think there's any other threat that is more existential to humanity, and there's nothing more health than the end of all of us. So for me, the climate crisis is the ultimate public health crisis. And it is not just an ecological or political crisis, it is a public health crisis. The issue and the interplay between migration and climate change is the fact that humanity's likely first response when they are threatened by some of the features of anthropogenic climate change is to move. So climate and migration are inextricably linked because that's our first and natural reaction. And once we move, there are ultimately very clear health consequences. Long before people start dying as a consequence of some of the factors I would talk about, people would start moving. The most immediate of those is actually rising sea levels. The projections and data suggest that even for major European and North American cities that are by the sea, in the coming years, rises modeled of sort of 1 meter to 5 meters in sea levels would result in the displacement of major economies and cities. People have to move. Okay, for those wealthy countries, the consequence likely would be moving hinterland and setting up new health systems to cope with displaced people. But for many poor countries, the consequence would be refugees that are displaced with very poor health and health systems. Of course, the effect of the climate crisis on resources such as food and security and competition for water also leads to conflict and ultimately the displacement of people. And those people that are displaced as a consequence of conflict will be refugees. And therefore, climate is, again, very closely linked. And the sad news is the data and the monitoring by an entity called Lancet Countdown, which is hosted in my faculty, suggests that for each of these factors that I'll talk about, the situation is getting worse, and it's happening right before our eyes. So if you take, for example, floods and droughts, the data are that the percentage of the world's land surface experiencing extreme drought in a given month reached a maximum of 22% in the period 2010 to 2019, a value that had only ever reached 13% in 1950 to 1999. There is no doubt that something wrong is happening and that this increase is not chance, and that we are going to have to move to accommodate that to different places where the effects are less. Wildfires. Again, the data, when you compare the period 2016 to 19 and 2001 to 2004, there are very high levels on extremely high risk of danger. Areas that are at risk of wildfires seem to have increased massively. We only have data on a subset of countries, but when you look at those countries where there's a high risk of wildfire and with actual evidence of more wildfire, there are more and more of them. Similarly, if you look at rising sea levels, which I alluded to earlier, again, the data are clear that if you take into account the sort of rising sea level that I mentioned of 1 to 5 meters, the projected number of people affected ranges between 145 million to 565 million. Many of the major coastal cities in North America and in Europe will be affected. Therefore, this is a tragedy and its health consequences, including why we site our hospitals, how we organize our health systems, that we cannot afford to ignore, with consequences on population movement. If you look at food security and undernutrition, using a proxy measure, i.e. change in crop growth duration, you can see for most of the cereals or grains that we talk about, whether it is maize or wheat or soybeans or rice, the trajectory has been in one direction, worsening of the situation in terms of scarcity of food and reductions in amount of cereals. If you look at the lethality, i.e. how many people are dying from these conditions, again, the evidence is absolutely clear. Between 1990 and 2019, the direction is one that things are getting worse. There are more of these events, and it is ultimately leading to harm, both in terms of poor health, but also deaths and displacement of people from where they normally are. My third and final case study, the health workforce, i.e. us, the healthcare workers, and where we are based. I will cover a range of areas in this, and then I would conclude. So firstly, the numbers. If you look at most of us that are working in high-income countries, the proportion of the health workforce in countries of the OECD that are from low-income countries and are foreign-born is huge, with some countries having nearly 40–50% of their health workforce, and others having varying proportions. So the UK sits at about 26%, and Germany sits somewhere here at about 10%. Huge numbers of movement of the health workforce from one part of the world to other, usually from a poorer country to a wealthier country. The percentage of that is also increasing, so it's not static. The trajectory is not that it's stable or it's going down. No, the numbers are actually going up, with consequences for those countries. If you look at the proportion of people that are moving, for some parts of the world, actually it's reaching crisis level. So for places in Africa, we're talking about between 10 to 30% for some countries of their health workforce. And similarly for areas of Oceania, the effects are huge, and some parts of Asia, the Caribbean, where it's approaching relatively high levels of people, both doctors and nurses, being poached by wealthier countries. So there are numerous benefits and obviously problems with this, and I'll try to summarize some of them. So firstly, to some degree, this concept of brain drain, i.e. people moving, would create shortages in those countries and ultimately a health crisis if we don't do something about it. And the size of the workforce living, the type of people living, and where they end up and their skill mix will determine whether it's the extent of the impact of this population movement. But sometimes also healthcare workers send money back home and they can support the health system or education, and that's a good thing. So the remittances and its huge size is actually a positive thing for many of these poor countries. The extent to which the effect is harmful depends a lot on whether there is actually loss from the perspective of resources being recycled back to train the next generation of healthcare workers. We know that remittances can partly offset that, but a lot of it depends on whether the resources are spent on key areas such as child health and on balancing the impact of the departure of healthcare workers, especially female healthcare workers from many of these countries. So often it just comes down to, are the remittances being used correctly to support those? The duration of stay of healthcare workers in rich countries is also absolutely important. So sometimes temporary migration, as long as there's acquisition of skills where they move, and that those skills are transferable skills that they can take back home and use, is actually a good thing. It could end up ensuring that those skills are adopted and used and health services are improved in poor countries, and therefore it would be a positive thing. But of course, permanent migration is ultimately a harmful thing, because then you can't replace those healthcare workers easily. So the global concept championed by the WHO on how we deal with this is some sort of voluntary code. So we don't want to stop individuals from their rights to be able to move, but at the same time, we want it to be managed in such a way that the sending country and the receiving country have got some understanding of what they want to do, the numbers, the process is fair and transparent, and people can move, acquire skills, and people can move back. And that where people move, it's done in such a way that they have the same opportunities as everybody else, and also that they can get induction and training and CPD opportunities in terms of their career development. We make sure that the principles that both source and beneficial countries are able to gain, and that health systems in poor countries are not made more vulnerable by the migration. We also need to make sure we implement measures to address the geographical maldistribution of healthcare workers between countries and within countries, and the importance of good quality data in that sense. It's not just doctors and nurses, though. This issue also affects care workers. And what this graph shows is the distribution by country of care workers, so people who provide care for the elderly. And with the aging population in Europe and in North America, this is inevitably just going to increase. And the provision of long-term care for our elderly will depend on people sourced from elsewhere, as it is the case here in Germany, largely arising from Eastern Europe, as well as in the UK from multiple other countries. You can see the proportions vary, but it's a general problem across rich countries. So the issue is, it is increasing. For most OECD countries, informal care is going to be an issue for most of us. The workforce is largely female, and they often contribute without getting any of the social protection that, say, doctors and nurses get, because they come in as low-skilled labor without opportunity to develop, and therefore, consequently, the effect is that they end up with less opportunity. I alluded to the fact that Germany gets healthcare caregivers from Central and Eastern Europe, and to some degree from the Mediterranean more recently. There are advantages here, some element of remittances, but the amounts of money in this space is much less, and there's a risk of the poverty trap where people earn very little and send all of it to take care. There's also the loss of workforce for the countries where these people are from, and also implications for each of these individuals, because if the mother in the house moves to provide care here, then they leave all the roles of childcare and all of the maintaining of home and stability to the male partners at home, and some societies are struggling with that challenge and the implications of the changing dynamics of households in those countries. We also need to be aware that because they earn very little, they are very vulnerable, and in the absence of social protection, that's a big issue. So I'll cycle back to the beginning of my talk to say we are not actually short of international conventions and the Sustainable Development Goals that guarantees the right of access to health care for all applies to migrants and refugees. We have an obligation as individuals, as healthcare workers, as scientists, to advocate for and make sure that migrants, one particular disadvantaged group, are not excluded from access to healthcare. Our countries have already signed up to these numerous documents. Whether you are a refugee or an economic migrant, we are all sort of in agreement that a certain minimum basic standard of healthcare should be available, and yet we don't tend to do it. So it is our responsibility to speak up and to advocate for this. And from the perspective of our commission, the Lancet Migration Commission, we conclude that the key way to achieve this are fivefold. First, we need policy and political engagement at the highest level. We need to make sure that our political leaders are listening, that this is a good thing for all of us to make sure that the health of refugees and migrants is better, because society will be better if that happens. We need to address racism and prejudice to make sure that the right wing do not take over the debate and misinform people with factually untrue things. We need to improve access to healthcare and health services more broadly for migrants, and we need better leadership and to hold those leaders to account through good collection of data with monitoring and accountability. Many thanks for listening.
Thank you very much for this very clear presentation. It's open for question and discussion.
Thank you very much, Ibrahim, for this wonderful presentation. I have a question on research. I know that the Lancet Commission doesn't do research, it just takes data that are available, which is a very good thing. But if you want to do research on this topic, you need to ideally follow the migrant from the origin, during the journey, at destination, at remigration, and so forth. Would you agree that very few studies do that? You either look at it from the parting, the origin, or during in a refugee camp, or at destination. You rarely have the full cycle. Is that correct? You're the expert.
Yeah, so when we did the Commission report, we actually looked critically at funding for research in this space, because without adequate funding, you can't really do what you described, which is the whole pathway of migration and understanding what's happening. And sadly, none of the major funders globally had dedicated schemes for migration and health. In my own portfolio of research as an active researcher in infectious diseases, I've often found myself applying for research on siloed disease area on a particular infection, and then reapplying the funding to address the migration and health issue. And I'm pleased that the European Commission has been very generous in that sense. In some of the TB work that we did with colleagues in Italy, we're able to do exactly that, follow migrants across the journey and their arrival in the southern border of Europe and the consequences of that to gain insight. But we could do with more. We could do with concerted efforts by the Horizon program and by other stakeholders to fund high-quality research that allows us to improve the provision of services and the quality of science that underpins policy.
Thanks for the clear-cut and well-organized talk. I just wanted, since you come from the UK, how did the situation of migrants in general and health care of them in particular change after Brexit, as compared to Central Europe, for example?
So in terms of strict access to healthcare, Brexit itself did not actually alter access to healthcare for migrants that are in the UK. But over that period, certain individuals from within the wider European Union suddenly lost their rights to certain elements of the ability to stay in the UK and the ability to access the National Health Service. And that has been so rather than changing the categories of healthcare that migrants can access, the removal of rights to a large number of individuals is probably the most harmful consequence of Brexit in terms of migration. In terms of going forwards and where we head with our current government that is pretty much continuing with a hostile migration policy, I'm not that optimistic that it's going to get better. Having said that, we, as I said, have an obligation to continue advocating because it is the right thing to do, but also because it's actually in the interest of the host population for that to be better.
Thank you very much for your very powerful presentation. Allow me one remark and one question. I'm very grateful that you mentioned the two cases of Ethiopia and Pakistan. Occasionally, I think in the light of man-made catastrophes, our efforts of health system strengthening or conceptualization of resilience, etc., are slightly belittled. You mentioned the lack of support to these two catastrophes of biblical dimension. What do you think are the reasons for that?
I think Dr. Tedros was right. I'm not very political, but I think you have to be blind to see that the key difference is race.
I would like to get to your notion of circular mobility, the right for mobility. I myself have spent a significant amount of my life outside of my home country, so I'm very much in favor of mobility. And I've also hosted a large number of young scientists from other countries in my center over the past few years or decades. And what I see is that in some cases, the circular idea doesn't really work. Like I have a female PhD from Pakistan, we just mentioned, who gave us a horrible talk about the situation of women. She had been working there, and she finally decided not to go back to her home country. And I can give you more examples, or it's a very intellectual PhDs from, or postdocs from China, who decided not to go back to a country that is a dictatorship and is becoming more and more clear. So how shall we deal with that?
So my response is, at the individual level, it's absolutely clear that the rights of the individual have to supersede any of our collective wishes, and that we cannot have policies that say enforce individuals to behave differently. But once you do that, I think it's within the gift of states, it's within the gift of large philanthropic and voluntary sector organizations to facilitate and make it easier for people to go back. If the reason for not going back is economic, for example, then it's fixable. If on the other hand it's political, because the political systems in the host countries are hostile, either in the form of rights of women or in fact a dictatorship that kills people, then you could see that it's really difficult to solve. And until you educate enough and the political systems change, it's not going to be easy to have circular migration. Ultimately, I think the organized effort of states and countries and the organized private sector to support people to move is the answer. And at the population level, I would hope that we can make a difference, even if we allow individuals to stay and have freedom.
Hello, Denise Manahan von University Bochum. Thank you for your very impressive presentation. There's so much to unpack in what you said, but I have one specific question with regard to mental health consequences. It's really clear that the Syrian diaspora, the Ukrainian diaspora, is inevitably associated with post-traumatic stress in those migrants and refugees. But in the case, the examples that you just gave of economic migration of healthcare workers, many become part of a society where they are culturally isolated, socially isolated, and they're simply to work. Is this an aspect that your Lancet Commission is taking into account and is assessing?
Yes. So the short answer to your question is yes. Obviously, I selected a few case studies to make a point, but mental health and migration is a whole talk that we could do for an hour. I have a PhD student that has looked at especially Syrian migrants, and she now works at the WHO. And there are numerous others doing research in the area. The Commission did look at that, and it's one of our major areas of work, both in terms of settled migrants in Europe, as well as migrants that are on the move, i.e. people along their journeys, as well as those that are trapped in refugee camps in places like Lebanon, where we've done a number of projects, and others have done, trying to understand the implications of those and the consequences on their mental health, which can be massive and life-threatening in many, many instances. The exclusion of people, once people have settled, is also a big driver. And I think there, as I alluded to earlier, societies have a moral responsibility to be more inclusive and to provide opportunities for people to integrate and to be the positive contributors to society that we expect other human beings to be. That is the ultimate solution to the mental health challenges. Obviously, in the short term, those that are suffering acute mental health needs can benefit from psychological support and access to good mental health, etc. But the ultimate solution lies in integration and support as appropriate.
Thank you very much, Ibrahim, for a very multifaceted and inspiring talk. I know you as a scientist, but you've also referred to yourself as an activist and as not being very political over the last 30 minutes. Where do we as scientists draw the line between being scientists and advocating for policy change in the view of massive crises, whether it's migration and health, the climate crisis, the corona pandemic? Any insights you'd like to share?
So my take on it is, as a scientist, I focus on questions and I focus on using the best methods. If there are laboratory methods, I would use that. And if it's an engineering solution, I would use that to answer the questions that I'm faced with. Once I have the answer and I have clarity that the evidence exists, I do believe I have a moral obligation to disseminate it. And our traditional approach has been to publish in journals. And we've done that for a long time. In some areas, that hasn't actually worked or changed policy. So in that space, we have, again, an obligation to move beyond that and to speak about it in the public space and to make sure that others with more power and the ability to change the world listen to us. And if they don't listen, we repeat ourselves until they do.